But we're ready to go. Welcome to this session. Yes, so all the comments about no sound, we apologize for that. The people were sending their details for CPD points. Please note you don't have to send in your details. We are still able to access your details once you register for the webinar, so there's no need to send in your details. Thank you. Quite a number of concerns about PPD and CPD points. I will find out. Dr. Raj, I will find out from Dr. Roslyn Kinuthia about your comment. All right, welcome to this afternoon session. And today we're going to have a very interesting discussion. We're going to have Dr. Anne-Marie and Dr. Karanja Shege, who will be taking us through inflammatory syndrome in children related to COVID-19. There's been quite a lot of discussion around Kawasaki disease and the clinical manifestations that look almost similar that present in patients with, in children with COVID-19 disease. So we're going to hear more from Dr. Anne-Marie Masharia, who's a pediatric infectious disease specialist at Kenyatta National Hospital, and Dr. Christine Karanja Shege. So Dr. Anne-Marie, let you start us off.
Good afternoon, everybody. Welcome to this presentation. Okay, so this is the outline of the presentation. We'll discuss the epidemiology of cases to date, the various terminology that is being used to describe this syndrome. We'll have a brief overview of Kawasaki disease so that we understand it and see how it differs from the MIS, when to suspect the multi-system inflammatory syndrome, its clinical features, what lab investigations need to be done, and a bit on the management. So what is multi-system inflammatory syndrome? This syndrome is also known as pediatric inflammatory syndrome, and it is a rare syndrome that is now being found to present in children with symptoms that are a mix of both Kawasaki disease and toxic shock syndrome. And there has been a possible temporal association with SARS-CoV-2 infection. So this is only being recognized as we get towards away from the peak of the infection, because a lot of data before was showing that children were only mildly infected. But as the infections peak, this syndrome has been seen to be appearing in children. So it was first described in London in a cluster of 8 children in about mid-April. These children were aged 4 to 14 years with a median age of 8, all previously well with no underlying comorbidities. 5 of them were male and 6 were of Afro-Caribbean extract. And the children presented with fever, variable rash, conjunctivitis, peripheral edema, and GI symptoms ranging from abdominal pain, nausea, and vomiting to symptoms almost mimicking appendicitis. All the children deteriorated to develop shock, and they needed varying degrees of hemodynamic support, including use of vasopressors and intubation. But 7 of the 8 children recovered. 1 child, however, passed away from a cerebral infarct when he was on ECMO. Soon after that, papers were published from Italy showing that there had been a 30-fold increase in Kawasaki syndrome recognized during the peak of the COVID epidemic. And since then, more than 100 cases have been reported in the United States, in most of the states, and over 230 cases reported in the European Union countries. So the 110 cases that we're presenting in New York have been characterized in terms of age. And you can see that it's a syndrome that is presenting primarily in children aged 5 to 19 and 10 to 14 years. That's one of the ways it differs from Kawasaki, which tends to present in younger children under the age of 5. So majority of children are in that 5 to 14 age group, with a few of them 15 to 19 and even fewer older than that. Of those that had been characterized, there seemed to be an almost equal number of white children and Black children. Data was unavailable for about 30% of them, and 3% of Asian children were infected. Again, another difference from Kawasaki, which we know is primarily described in Japan. So what is this syndrome exactly? Its pathogenesis is unknown, and it seems to be an abnormal response to SARS-2 infection. It is thought to be possibly an antibody-dependent enhancement, because we said it's coming almost after the child seems to be in the recovery period, because most of the children are testing negative by PCR. And it's thought that maybe the antibodies that are produced are somehow allowing the virus entry into cells, causing a sort of multi-system involvement. It's also thought to possibly be due to a cytokine storm, similar to what was being observed in adults with acute respiratory distress syndrome, because they've been found to have higher levels of interleukin, such as interleukin-1 and interleukin-6. And of note is that it is primarily post-infectious, as we'll see even when we get to the WHO definition, because many children who are swabbed at that point are actually negative by PCR, but where antibody tests are positive, those have been positive in where antibody tests are available, those have been positive in a number of children. And in a number of children, you can also trace contact where family members have been positive for SARS-CoV-2 infection. So we'll just do a brief review of Kawasaki disease, just to remind ourselves what it is, because the two syndromes are very similar. And indeed, we did have one child presenting in our facility who seemed to have a partial Kawasaki illness. So Kawasaki is an acute febrile vasculitic syndrome found again, like I said, in early childhood, primarily children under the age of 5 years. And its main pathology is that it affects the medium-sized arteries, particularly the coronary arteries. This syndrome was first described in 1961 and primarily in Japan and Asian countries, but since then it's ubiquitous, found all over, and the causative organism is unknown. It seems to be triggered by several viral infections. It is usually self-limiting and will last approximately 12 days without treatment. The main problem being the cardiovascular complications, like we said. 10 to 15% of the children develop aneurysms if it is untreated. And this may lead to coronary occlusion and cardiac ischemia. So in the acute phase, the child may have a prodrome of either gastrointestinal symptoms or respiratory symptoms that are with a high fever that poorly responds to antipyretics. And then there are the signs and symptoms of mucocutaneous inflammation, including a bilateral non-exudative conjunctivitis. That means that the conjunctiva are red and inflamed, but there's usually no accompanying discharge, or the sort of sticky eye that is typical of a bacterial conjunctivitis. There is also erythema of the lips with cracked lips and reddening of the oral mucosa, what is known as a strawberry tongue. And I'll show you a few images after this. The rash is polymorphous, meaning there's no standard description of it. It may be papular, it may be macular, it may be maculopapular, and it's accentuated in the groin region. So within the folds, it's where it is most marked. Please note that it is a non-bullous rash, so no blisters develop, so it does not resemble chickenpox. And there are also changes in the extremities, including indurated edema of the dorsum of the hands and feet. And this is usually one of the last symptoms to develop. The child may also have a cervical adenopathy, which is usually painless, usually unilateral, and the node is quite large, usually more than 1.5 centimeters in diameter. And there is also extreme irritability, particularly in infants. So as you can see from those images, that is what the conjunctivitis looks like. So no discharge, but the conjunctiva is quite red and inflamed. The second image shows you an irritable child, and I hope you can appreciate the cracked, dry lips. which are also depicted in the next image, which shows that red strawberry tongue, where the papillae of the tongue stand out as looking a darker red, and the tongue takes on a more red color than usual. And you can see that the lips are very dry and fissured. In the next image, there's a child who has a right-sided cervical adenopathy, and that node is quite large. You can see some rash in the next picture. I don't know whether you can appreciate that desquamation on the palms of the hands. Again, an irritable child, and the other images below that depicting the edema that you get on the dorsum of both the hands and feet. So the disease continues to evolve, and in the subacute phase, once the fever has resolved, the desquamation of the digits may then start. And that fever phase, the subacute phase may last a period of 4 to 6 weeks. And this is when the coronary aneurysms may develop, leading to sudden death. Yeah, so we'll see that involving the cardiovascular team, the cardiologist early is very important in management of these children. In the convalescent phase, there's complete resolution of all those inflammatory signs and symptoms, resolution of the fever, and all the raised acute phase reactants will return to baseline. However, it may be during this phase that a child who had not received intravenous immunoglobulin may then have a development or worsening of the coronary aneurysms. And the chronic phase in those children who do not fully recover is marked by long-term cardiac complications, especially signs and symptoms of myocardial ischemia from the thrombosis within those aneurysms, which may present with chest pain, abdominal pain, or palpitations, and arrhythmia if it is recognized and seen on an ECG. So to make a diagnosis of Kawasaki, you need to have a child who is presenting with fever, usually for more than 5 days, with 4 out of 5 of the following mucocutaneous syndromes. And you can see there's a nice acronym there to help you remember, CREAM. So conjunctivitis, which we said is usually non-exudative, a polymorphous rash, edema, or just erythema of the hands or feet, adenopathy, which is cervical and often unilateral, and any other mucosal involvement, meaning erythema, usually of the mouth with fissures or crusting. So having just reminded ourselves what Kawasaki is, how does this multisystem inflammatory syndrome differ from, or how is it alike to the Kawasaki? So these are the presenting symptoms for the multisystem inflammatory syndrome, and they've been put there in order of how frequently they have been observed to occur in these few children who have been described, the 100 or so children. Fever is almost universal at 100%. And the next most common presenting symptom is gastrointestinal, with pain, vomiting, diarrhea in about 60 to 97% of the patients. Rash is fairly common in 50 to 60% of them. Neurocognitive symptoms, which are not part of the Kawasaki syndrome, are also fairly common. And this may range from headache to lethargy or confusion. Respiratory symptoms are not universal and are thought to be more because of either a child who is presenting with shock or dehydration. They've not been a prominent part of this syndrome. Conjunctivitis is present, mucous membrane involvement in about 20%, while others like sore throat and swollen hands and feet occur in a smaller proportion of children. So that image contrasts the two symptoms. The things that are highlighted in red are what are common to Kawasaki. That's the conjunctivitis, fissured lips, cervical adenopathy. And note that there may also be mesenteric adenopathy, which will just present with abdominal pain, maybe some diarrhea or vomiting. And then the coronary artery dilatation and pericarditis. Neurological signs, REPS signs, and nausea, diarrhea, and vomiting are more found in the multisystem inflammatory syndrome rather than in Kawasaki. So those are the ways in which those two syndromes differ. In addition, the children are older, like we can see the median age is 10, and even in that population described, you could see their ages. The majority of them were falling in that 5 to 14 age group. So the clinical findings, again, put in order of frequency, are shock, usually as a result of dehydration or because of the vascular involvement, and then you get into a hemodynamic warm shock. Some children have the complete criteria for Kawasaki met, many of them: myocardial dysfunction, acute respiratory failure, acute kidney injury, serositis, which may present with small pleural effusions or an acidic small ascites, and a few children have had acute hepatic failure. So you can see it's actually involving almost all the systems in the body. So which labs should we do? We're just going to look at what the common findings have been, again, in this population that have been described. And later on, we look at what we should do for any child who we find presenting with these symptoms. So in the full blood count, 80 to 95% of the children have had a lymphocytopenia. But neutrophilia is also present in a large number. Mild anemia is also fairly common at about 70%, and 30 to 80%, I know that's a very broad range, have thrombocytopenia. One thing that we do need to do is inflammatory markers, especially the CRP and ESR, which are readily available in most of our facilities. C-reactive protein is elevated in 90 to 95% of these patients, as is ESR. For the more severe patients, you may want to also do D-dimers, fibrinogen, and ferritin, which are also elevated in the proportion of patients shown. In addition, cardiac markers, particularly troponin and brain natriuretic peptide, have been found to be high. Some patients have presented with hypoalbuminemia and mildly elevated liver enzymes, and we saw that a tiny proportion of them do develop hepatic failure, and elevated LDH is found in about 50 to 60% of the patients. Imaging is very important, and the imaging features that have been described, the main one is left ventricular dysfunction. This has been found in 50 to 60% of the patients. A fewer proportion of them have presented with mitral regurgitation and pericardial effusion. So you can see there a coronary angiogram. So the image on the left just reminds us of the anatomy of the coronary vessels. So there's the right coronary artery, and then the left coronary artery, and the circumflex and left anterior descending. And then on the image alongside it, you can see the vessels on the left, which show the coronary artery dilatation. In this syndrome, a higher proportion of children have been found to have coronary artery dilatation, 20 to 50% of them, in contrast with the 10 to 15% who may have that in Kawasaki disease. Chest radiographs have not been remarkable. A good number have been normal or have shown small effusions or patchy consolidation, and chest CT scan may also not be of great value, have shown similar picture to the chest radiograph, and a few have had the typical ground glass appearance that has been associated with the adults who have ARDS. If an abdominal ultrasound is done, has been done for a few patients, some have had ascites and signs of bowel inflammation. So after all these cases began being reported, CDC and WHO both came up with a preliminary definition. It's of note that this is a syndrome which is still under investigation. It is just only newly described, and it's important for us as clinicians, especially when we get into a situation where we're having more community spread, just to be aware. And for us to classify a child as having that multisystem inflammatory syndrome, we'll just go through what the WHO says. There are a number of criteria, but just document whatever you have and maybe share findings even in our calls, or feel free to consult any of the consultants here should you have children presenting this way. So they're all children or adolescents aged 0 to 19 years who have had fever for more than 3 days, and any two of the following. So a rash or non-purulent conjunctivitis, or any mucocutaneous inflammation that's in the mouth or the swelling of the hands and feet that we have described. A child also presenting in hypotension or shock, having features of myocardial dysfunction. That means that on X-ray you may appreciate a pericarditis, valvulitis, or abnormalities in the coronary vessels found on echo, or through the increased markers that we have talked about, like troponin. Evidence of coagulopathy, including elevated prothrombin time and PTT, or elevated D-dimers, or presenting with acute GE. Now this sounds like many of the presentations you see. We've talked about presentation in almost all the systems. Yeah. And you can see many of those are features also found in Kawasaki. In addition, if you do labs, there should be an elevated CRP, ESR, or procalcitonin. Procalcitonin was not elevated in many of the patients, so for us, we can rely on the CRP or ESR. It's important to note that there should be no other obvious cause of inflammation, bacterial, staphylococcal, or streptococcal shock. And lastly, evidence of COVID-19, either through the PCR, serology, or having a likely contact. So if you do get a patient who is presenting with any of those symptoms, how should you manage them? Majority of them will be stable patients. If they have only had a fever greater than 3 days like we have described, or have mild symptoms, the initial investigations should include a full blood count and CRP. If the patient has an elevated CRP, that is a patient who you may want to keep in hospital and monitor in case they do start to deteriorate. Any patient who presents with any of the other symptoms or is severely ill, either moderately or severely, then these are the investigations that should be done, including a full blood count, inflammatory markers, ESR and CRP, their liver function tests, lactate dehydrogenase and urea, creatinine and electrolytes, a serum ferritin, a coagulation profile, cardiac markers, including troponin, CKB, brain natriuretic peptide, a urinalysis. In places where it's available, they've also been doing a cytokine panel. It's important to rule out other infections. Yeah, the advent of COVID does not mean that other bacterial infections are not occurring. So carry out a full septic screen, including a blood culture, a urine culture, a stool culture, a chest X-ray. If available, a full respiratory viral panel should be done. If available, also do EBV serology and PCR, as well as CMV serology and PCR. Sorry for the typo, just to rule out other viral etiology, as well as enterovirus and adenovirus, which may also cause a septic shock picture similar to that being seen with these COVID patients. Cardiology review is very important. As a bare minimum, the child should have a 12-lead ECG and an echocardiogram done. If it is initially normal, the echo should be repeated 2 weeks after this diagnosis has been made. And if in the initial echo, the patient had any signs of coronary artery dilatation or aneurysm, it should be repeated every 2 to 3 days until the child is stable, and thereafter weekly. At this point, there's no guidance for how long this monitoring should go on. If the child had any signs of systolic dysfunction or myocarditis, manage as necessary and repeat the echo as indicated by clinical symptoms. It's important to just make sure that you rule out all other differential diagnoses for which treatment is available, including bacterial sepsis, Kawasaki disease, in our setting, malaria, meningitis, toxic shock, appendicitis, other viral syndromes, and other inflammatory syndromes such as HLH, histophagocytic Langerhans, and macrophage activating syndrome, as well as SLE and other vasculitis. So how should these patients be managed? So we said that the moderate to severe patients need admission. Stable patients whose inflammatory markers are elevated need admission for monitoring until their CRP and ESR start to go down. The other patients ideally should be managed in a HDU or ICU setup, having a multidisciplinary team caring for them. So if they have multi-system involvement and shock, start antibiotic therapy as we always do for septic shock. Trials are being done, and one antiviral that has been used is remdesivir, where it is available. Remdesivir has been shown to shorten the hospitalization period from about 15 days to about 11 days. The only challenge with it is that it needs to be instituted early for it to have maximal benefit. So we don't know how soon that will be available for us outside of research settings. Management of shock should continue as we usually do with fluids and vasopressor agents if necessary. There have also been immune modifying therapies tried, including glucocorticoids, interleukin-1 inhibitors like anankinra, and interleukin-6 inhibitors. where available. So this algorithm just goes through the management of Kawasaki, because for us, a patient presenting this way and is fulfilling part of the criteria for Kawasaki disease, then we need to institute the therapy we have available. And if you look at the left-hand side of the algorithm, the standard initial therapy is intravenous immunoglobulin together with aspirin. In consultation with the rest of the team, including the cardiologist if available, glucocorticoids like prednisone can also be tried. I won't go through the full algorithm, but I'll share these slides so that perhaps you can just look through them and have them as a reference point. What is the prognosis? So out of the cases described to date, it's good that most children survive when they are given the adequate care in the best of these facilities. As of mid-May, 5 mortalities had been reported of the 230 suspected cases in Europe. So what is our takeaway message from this presentation? Of note is that coronavirus still affects just a small proportion of pediatric and adolescent patients. Obviously, as we start to describe these more severe syndromes, it may put a lot of anxiety in us, but the idea is just to sort of be ready, because these children started to be seen after the peak of the initial infection. It's something that seems to happen when they're in that recovery period. However, overall, children are still the lowest proportion affected out of all the COVID cases, just 2% of the US cases, 2.2 in China, so around that range of 1 to 2%. The children most at risk of severe illness are those with chronic illness and immunosuppression, although this particular syndrome is being described in healthy children. Please note that it's an atypical presentation that may occur weeks after the initial infection. So manage symptoms of Kawasaki if you have the medications available, but don't forget to always manage any underlying or presenting condition in children. Thank you.
Thank you so much, Dr. Anne-Marie, for that eloquent presentation. Let me find it. Before we go to the Q&A section, Dr. Christine, would you like to add an input to that presentation? Okay, so as we wait for Dr. Christine to join us, maybe we can go briefly and very fast through the Q&A section. I'd also like to introduce you to my co-host, Dr. Nancy Ngumbao. Yes.
Good afternoon, everyone. It's been an interesting presentation from Dr. Anne-Marie, and so we'll be moderating the session with Dr. Rhoda Kalondo. Dr. Christine Karanja, can you hear us?
Yes, I can.
Do you have any input on the presentation, or should we proceed to the Q&A session?
I can just give a few remarks. Can you hear me clearly?
Yes, we can.
Okay, thank you very much. That was a very comprehensive discussion. I just want to lay emphasis on a few things about Kawasaki. First, just to say that we've been having cases in Kenya. We cannot say that they are related to COVID, but we did get a few spikes. All the way from December up to March, mid-March, we had a few sporadic cases, even in the counties and the private hospitals. So I would just like to emphasize that the greatest threat of Kawasaki is the long-term cardiovascular effect, because the vasculitis really predominantly affects the coronary artery. So it is prudent that we should find a way of sourcing IVIG, because IVIG is what really makes a difference in terms of coronary artery and acquired heart disease later, even in adulthood. Other than that, it is also to make a point of involving the cardiologist early, because they can detect the coronary artery dilatation even before it goes to aneurysm. So let us not take it lightly. The other thing to emphasize is that irritability is a very key feature of these children. They tend to be practically inconsolable. So when you see a child with a very high fever, a fever that is spilling into its fourth day with a rash, very red lip, that is Kawasaki until proven otherwise. So we should always have it as a high index of suspicion, especially in children below the age of 5 years presenting in such a manner. Thank you. Over back to you, Rhoda.
Thank you so much, Dr. Christine, for that input. I've seen your sentiments are being echoed by Dr. Warurua, who is saying that thanks, Masharia. And she's saying that, could we have had this syndrome in Kenya January to March, where we had a ruse of kids admitted early this year, which are likely trigger viruses of Kawasaki. So Dr. Mugo is agreeing with you that we might have had that trigger, as you've said, between December and mid-March. We might have had a lot of children presenting with that. So she's asking, what are the trigger viruses for Kawasaki? Dr. Anne-Marie?
Yes. Like I said, no infectious agent has ever been identified for Kawasaki with a clear link to majority of the cases. However, that whole viral panel I put there, the enteroviruses, the usual viruses that children are coming into hospital with, are thought to be a possible trigger, because the prodrome is usually the respiratory syndromes or GI syndromes. So I think their suspects have been like adenovirus, the rhinoviruses, the human metapneumoviruses, which by the way have been found in a number of COVID cases, but none has ever been convincingly linked with Kawasaki disease. So its etiology is not known, but it seems to be a sort of inflammatory syndrome that is triggered by viruses, including now what we're seeing with COVID.
Okay, thank you for that. Jojo Witty, I hope your question has been answered. You're asking about any cases in our current setup. I hope it was answered, but maybe Dr. Anne-Marie could also reinforce on that.
Yes, I mean, a lot of people do think that we probably had coronavirus circulating into the country even before the initial official announcement. So it is possible, because pediatricians had, we have a group where we are discussing many of these cases, and people did say they were seeing a lot more Kawasaki in hospitals, both not only in Nairobi, but like Christine has said, even within the counties.
Okay, thank you. Thank you for that. Somebody's asking, Nathaniel Msioka is asking, are the symptoms, COVID-19 symptoms, different in children than in adults? Is there a big difference between the presentation, the way the children present and the way the adults present?
Okay. Literature has shown us that majority of children are asymptomatic. This seems to be the case here as well, because we have far more stable children and adolescents in quarantine at Mbagathi Hospital than we have positive cases within the hospital. And I think in absence of a specific medication for COVID-19, I think that's why as pediatricians, we have been emphasizing, look for any other cause for why this child is sick. Do they have bacterial sepsis? Do they have malaria? Do they have meningitis? And treat the underlying condition. The respiratory presentation does not seem to be as common as it is in adults. If I speak to the 2 or 3 children we have seen who have been COVID positive and have since recovered, one was an 11-year-old child with an underlying malignancy. He had a B-cell lymphoma, a tumor in his eye. He did have respiratory symptoms, but even from the point of admission, this had been attributed to the child's anemia. And indeed, with supportive care, just transfusion, antibiotics, and oxygen, which was delivered only by non-rebreather mask, the child's COVID test came back negative after about 7 days in the hospital. And we are now able to carry on with his more definitive treatment. We've also had a 1-year-old child who has cerebral palsy, who came in with uncontrolled convulsions, possible meningitis and pneumonia. After a week of antibiotics, the child is stable and doing well. and is actually off oxygen. He's only here because his test is still positive. So the presentation in children, it may be that a child has come in with another comorbidity and COVID test is positive. So do still go through the regular pediatric algorithm and treat the conditions that you can treat. I hope that answers your question.
Thank you.
Thank you for that response, Dr. Anne-Marie. Dr. Mugo.
Yes, please.
Hello, Dr. Arurua Mugo.
Yes, Dr. Can I make one or two small comments?
Yes.
Okay. Now, I would wish just to concur with Dr. Christine Chege, especially about the high fever. Fever can be very annoying between 38 to almost 41 for a very long time and can bring a lot of dispute amongst the doctors.
We've lost him.
Hello, Dr. Mugo. Okay, sorry, we seem to have lost Dr. Arurua Mugo. We'll just give him a few minutes to get back online so that you can hear his comment. But in the meantime, I'd like to ask Dr. Muiva to make a comment or ask a question. Hello, Doctor. Okay, Dr. Arurua.
Hi.
Hi.
Hi, can you hear me?
Yes, we can.
Sorry, my network's breaking up.
That's okay. That's okay. Just proceed.
No, it's just to say thank you so much for the excellent presentation. And to say that we've learned a lot, I think. We need to also remember that GI symptoms occur quite frequently in these children. So we don't need to just be thinking only when we see these children with fever and diarrhea, only about the normal complications. We actually need to be thinking about other things. But thank you.
Okay, thank you so much, Dr. Muiva, for that comment. And I agree with you. We need to look at for other signs and symptoms. Dr. Arurua Mugo, are you back? Okay, we'll just give him a few more minutes. In the meantime, Dr. Diana Marangu is, oh yes, Dr. Arurua Mugo.
You can hear me now?
Yes, you can.
Excellent. Maybe, Kalondi, if you allow me just have a minute comment.
Yes, go ahead, go ahead.
Okay, I had mentioned that totally agreeing with Dr. Christine Chege on a very, very high fever that can go for a long time. And usually you get a bit of dispute among as the healthcare workers, whether we go to aspirin or paracetamol or what we need to use. And I guess aspirin is very key in these children. That's a Kawasaki. Then the swelling of the legs and the hands are also quite obvious, but you wonder whether is it due to the CCF or is it due to the inflammation? I think those are some of the questions that we ask. And then finally, encouragement of the parents is absolutely important through psychosocial support, even counseling. Thank you, and over.
Thank you, Dr. Warurua. I would like to ask Dr. Diana Marangu to also comment on this.
Thank you very much for the excellent presentation. I'm sorry I joined in a little bit late. I have a few questions. Beyond Kawasaki, what other inflammatory conditions should we be looking out for? Remember, context is everything. Perhaps we are seeing other things that are not being fully explained. And I would like to throw that to Dr. Macharia and also the other panelists. Secondly, is the question about our testing strategy. I'm curious in terms of, given all this, I mean, it's very, this disease is very non-specific, especially in children. But it's important to note all the children you've talked about, even in the KNH aspect, actually did have respiratory symptoms. So the targeting strategy, beyond just respiratory symptoms, are we testing everyone who is hospitalized? Thank you, and over.
Thank you very much, Diana. I'll start with your second question of the testing strategy. I do agree with you, and I think there was even a move earlier to say that all hospitalized patients should be tested. Because I guess as we get a larger number of patients, we may not be so concerned about those in the community, except in terms of controlling spread, but knowing within the hospital how many of those are infected. And I think this is where we are going to move towards, and hopefully sooner rather than later, especially for our children who we've seen the presentation is actually almost all the things that a child would be coming into your casualty with, from CNS to rest manifestations to GI manifestations. For your second question, I'm not sure what you had in mind in terms of the inflammatory syndromes that may mimic this. Like we said, septic shock, that could just be the presentation. And we do see many children coming in with that presentation. We did talk about syndromes like HLH and MAS, which have a specific diagnostic criteria, but are also fairly non-specific syndromes. So I'm not sure what you have in mind. Perhaps you can share.
Thanks, Dr. Macharia. What I was just questioning is the experiences that people have had. So I know everyone has been very alert for Kawasaki, but beyond Kawasaki, I think you've mentioned this. I wonder if in the audience, people are actually testing these children who are coming with presentations that are not, either they're common or they're not common. They're hyperinflammatory symptoms. Are we actually testing these children? So it's rhetoric to some extent. So it's just to throw it to our audience to consider the testing in all these children in whom we can't fully explain what's happening, or even we can explain, but we should consider COVID-19 at the back of our heads as a comorbidity. Thank you.
Thank you, Diana. Absolutely. Like I said, I think every child or every person coming into hospital should actually be tested. Of note, again, like for the children with MIS, the test may be negative. So it may be that there was history of family members who were positive, or when we do have antibody tests available, then we'll see that they had indeed already been exposed to COVID-19.
Thank you very much. We'll proceed with the question and answer section. And I know a lot of the people are concerned in terms of the majority of children who present at our casualty with fevers and abdominal pains. And I think the issue of testing has been addressed by Dr. Macharia. So this is from Dr. Kirana Bhatt. What can a cardiologist offer even if coronary dilatation has been diagnosed early? Can long-term complications be avoided?
I think Dr. Christine had responded to that. Dr. Terry, do you want to respond? Sorry.
Okay, hello. I was busy recording questions on the chat. Okay, please could you repeat? I missed that one. I'm responding to you and then I'll be along. Just try to repeat the question.
The question that was asked was concerning what a cardiologist can do concerning the Kawasaki syndrome. Can long-term complications be avoided? So what can a cardiologist offer?
What a cardiologist offers is when you put the patient on the low-dose aspirin, you prevent any thromboembolic complications. And then on the other hand, if you monitor this patient, you're able to find if initial damage from the vasculitis had not yet caused the aneurysms, but they develop later, the cardiologist can follow up for that. And then any ECGs that look abnormal, maybe from the following myocardial damage that was not eventually found, that one can also be followed up. So it's very, very, very important. Right from the word go, send these patients to the cardiologist. The cardiologist will follow. It's very, very have them followed up. Thank you.
Thank you very much. Another question. Another question from Julius Odhiambo. He's saying the doctor is directed to Dr. Macharia. Why is it that most children with SARS, with the COVID-19 associated with pediatric multisystem inflammatory syndrome have a PCR test negative while antibody positive?
Where this syndrome has been described, it seems to mainly occur after the child's PCR is already negative. The etiology is not known. Like I said, it's thought to be maybe some overstimulation of the antibodies that is then allowing the virus to attack cells in various systems, but poorly understood. Data is actually still being collected by WHO and CDC to properly characterize this syndrome. And perhaps we need to find a way, even for us locally, to be able to collect data on our own children and describe it, because many clinicians feel that we've already seen this syndrome early. I saw in the comments that some of the children seem to have recovered without sequelae for those who have been followed up, but it seems to present after the child has already produced antibodies and is now negative for COVID-19.
Thank you very much, Dr. Macharia. Another question from Nicholas Ndwiga. What intervention would you recommend for a suspected case at a remote retail facility to enable a child reach an established medical facility? I'm assuming the question is thinking about the rural setups and where they can't get anything else.
Aspirin is a fairly common and inexpensive medication. I feel that should be available even in our smallest facility. Intravenous immunoglobulin, which we've said is a standard treatment, while not readily available, makes a big difference in the prognosis of the children who do have coronary syndromes. And maybe some of our efforts should be directed at making this available if this is a presentation that is occurring in many of our children, especially as we get more and more cases.
Thank you very much. Dr. Wambani, I'll give you the platform to make a few comments and ask any questions.
Thank you very much. Mine is a comment and a question at the same time. This is a very good presentation. And as far as I can remember in children, it's so difficult to know, to make a diagnosis. And I would just want to find out, is there one particular sign or symptom that you can look out other than comparing it to Kawasaki? And just look at, in our local setup, what is one particular thing that is unique to this syndrome? Because if you look at, first you said that you don't have very many children affected in the introduction, and now you say it is common to other presentations. And in children, most of them will have fever, will have GIT complications, and this rash is like, is there a way you can describe It is the only thing that is a bit something that can be described, whether it's maculopapular or whether it is what sort of rash. I think we should look in respect on what one thing in particular in our setup could we, zero in as something that is suspect, so that we don't get those cardiac complications.
Thank you, Dr.
Okay, let me
Go ahead,
try
Christine.
and answer that one. For the Kawasaki syndrome that we have seen in Kenyan children, it does not differ from the one that is seen in the West. The red eyes are there. The red oral mucosa and cracked lips are there. The rash is what we describe as a polymorphous rash. It initially tends to be erythematous, maculopapular, and then in the later stages, maybe towards the end of week 1, week 2, it starts desquamating, especially in the extremity. The key thing about these patients with Kawasaki is that they actually really appear unhappy. But the fevers, even with antibiotics, do not go down. You kind of approach the 4th day, the fevers are still as high. And the strawberry tongue is just the same strawberry tongue that you see in infants of any color. So if one is not sure, just call a pediatrician. And also, if you want to see anyone Kawasaki, you will never forget. And then remember, we can also have incomplete Kawasaki or atypical Kawasaki. They don't have to fulfill the 5 out of 6 criteria. Some of them do not even have the lymph nodes, but they have the other features. So the rash is polymorphous. It's not a measles rash, it's not a vesicular rash, but it's predominantly maculopapular and then desquamate later. And then remember, the edema is not usually present early. Edema comes later, but they have erythematous palms and toes. They may have redness or even just warmth of the palms and toes. So those are just things to look out for. I will leave Anne-Marie to answer the rest of the questions, Dr. Wambani.
I completely agree with Christine, because it is not any one specific symptom or sign, Dr. But I think finding those symptoms together, having the fever with that mucocutaneous involvement being the main thing that will put a trigger. One child who came in, the clinician actually referred them thinking that they had measles. So, like Christine is saying, that rash is the maculopapular one that we have been used to seeing with children initially when we had many measles cases. But the main thing is that it is not a blistering rash. At some point it was being likened to chicken pox, but there are no blisters or vesicles. Yeah, just either redness or small papules or macules. Have we answered your question, Dr. Wambani?
Yeah, somehow. My other comment is, in the rural areas,
Yes.
if you are able to get this where you don't have pediatricians and you have maybe community health workers who are going around, what one thing would you tell them to look for in children? That is what I would like us to look at. And if there isn't one other thing, then we should alert them on 2 other things to look at.
Okay.
Just for the sake of diagnosis and for the sake of helping out, so that we don't have a lot of children from the rural area coming to the main hospitals with cardiac lesions.
Okay, I agree. So maybe the emphasis is on the fever that is not responding to antipyretics and the irritability, like Dr. Christine has said, together with rash and red oral mucosa. Yeah. So we've been used to recognizing measles, so it's a syndrome. It's sharing some of the features of measles. Okay. But I think this kind of raises awareness so that if you see this set of symptoms and you're not sure, I think people are always ready to consult, even by phone. And there are pediatricians in, I think, all of the counties that can be reached for their thoughts.
Thank you.
Thank you, Dr.
Thank you. Thank you so much for that discussion, Dr. Wambani and Dr. Macharia, and also Dr. Christine. I'm seeing you've addressed quite a number of questions just by addressing that concern. There are quite a number of people who are asking, what should I do? What signs should I look out for? I work in a community pharmacy. Brian Agwambo is saying that he came across a family whose main concern was the child died of skin rash. And despite being given Ampiclox plus topic antihistamine, the symptoms persisted. Is this related to Kawasaki? There's something Dr. Christine mentioned. Please consult a pediatrician. I can see there are quite a number of, there's a request for dosage of aspirin in children. There's another request for how do we diagnose this. Please, if you work in a community pharmacist and you're in a pharmacy and you're listening to this, if you work in a laboratory and you're listening to this, if you work in a clinic and you're listening to this conversation, my request would be please send this child to hospital. Otherwise we'll start putting so many children on aspirin, self-medicating them, and we will not be doing them any justice. We'll not be doing those families any justice. So please send them to hospital, let the pediatrician see them. And that's the only way we'll be able to get also data. And if we have somebody from Mandera sharing the experience about a patient they saw, another person from Busia, another person from Machakos, another person from Mombasa, then that's the only way we will learn that the Kenyan presentation for COVID-19 in children presented this way. That's the only way we will learn how our population presents. So my kind request, as we're asking about all this, what should I do? Send the child to hospital, refer that family to hospital. Okay, Dr. Ngumba.
I'll ask the question from Peter Njoroge. Now that we are discussing giving children aspirin with the suspect of Kawasaki, so what's your take on the incidence of Reye syndrome in pediatrics less than 12 years put on aspirin? This question is to Dr. Christine Karanja.
Okay. With regards to Reye syndrome, first of all, let me say it's quite a rare syndrome. And with most things, we have to weigh the risk-benefit. So, for the risk-benefit analysis, aspirin here clearly outweighs the risk. So, and in my not too long career, I have not seen a case of Reye syndrome, but Dr. Mogo is here with us. He has a longer career than me. He can tell us whether he has come across Reye syndrome. But Reye syndrome here, not an issue. The heart condition, the Kawasaki, we should give the aspirin. Thank you.
Thank you very much, Dr. Christine.
May I add on that, Dr. Kalona?
Yes, you can add.
Thank you. Thank you, Dr. Christine, for that comment. Due to this issue of thromboembolism, which can be very, very risky, even causing ischemic issues in the brain and in the heart, the usage of low dosage aspirin is really vital. Alongside with the immunoglobulins, they'll save the child progressing to either the coronary issues or the ischemic issues in the brain. I have not also, despite reading about the Reye syndrome, come across that, although we have used quite a bit of aspirin in a number of children, at least more than 10, but we have not seen them coming back with features which are described with the Reye syndrome. So I'll still go ahead and recommend low dose aspirin, and then very important, immunoglobulins, because they change the pattern of the presentation for the better, and especially the coronary issues. Over.
I can see Dr. Kiraito had raised their hand, so you can ask your question. Dr. Kiraito?
Okay, thank you for that. Dr. Kiraito, we'll give you a few minutes to get back and ask your question or give your comment. Elizabeth Shiundu, would you like to add an input or ask a question? All right, I think we also give Elizabeth a few minutes. There's another raised hand. It's a device called OPA1, so we'll give you, let me just allow you to talk, but in the meantime, we'll, all right. Kindly unmute yourself and ask your question. And as we continue to go through that, there's somebody who just said they joined in a bit late and they wanted to find out, to know the symptoms, the other symptoms other than fever. What are the other symptoms? Maybe Dr. Anne-Marie, you can just put on the screen the symptoms so that the person can be able to know what to look out for. And there's a question from Ogola who's saying, when should we start immunoglobulins in Kawasaki while most of these diseases are self-limiting? So at what point do we start the immunoglobulins, Dr. Anne-Marie?
Like we have said, initially you don't know which patient is going to progress to the cardiovascular manifestations, and giving the treatment early, the immunoglobulins and the aspirin may actually prevent the child from getting the cardiovascular and thrombotic complications. So that is treatment that should be instituted at diagnosis. I'm just going to go back and display the symptoms here.
Thank you very much, Dr. Masharia. Oppo A1K, please, you can unmute myself and ask your question. In the meantime, I'll ask a question from Kevin Morioki. Is Kawasaki Syndrome contagious? This has been asked by many people, so I'll direct it to Dr. Christine Karanja to tell us.
Okay, thank you for that question. Kawasaki syndrome is not contagious. The thing with the Kawasaki syndrome, there are times it appears to occur in clusters. Maybe perhaps because of a circulating unidentified virus or bacteria that may trigger in a certain group of children who are in one vicinity to manifest that way. That's why sometimes you can find clusters of Kawasaki coming from one locality, and then you start thinking it is contagious. But most cases of Kawasaki are actually sporadic. They may occur in one child and not in another. And then we do not exactly know the trigger. It can be an infection. It can be anything that triggers an inflammatory response, an uncontrolled inflammatory response.
Thank you very much, Dr. Kristen. I'll allow Dr. Mary Beth Maritim to weigh in or ask her question. Dr. Maritim? Okay. Dr. Kiraito, are you on to ask your question? Okay. So there's another question from a number of people trying to describe the nature of the abdominal pain. So in which region is this abdominal pain in terms of quadrants, or is it on the 9 regions? Is it dull, aching, burning, or knowing? And how do we prevent these children from undergoing surgery because of the diagnosis of acute abdomen?
Thank you for your question. I don't think the nature of the pain has been characterized, and GI symptoms have ranged from just pain to also having nausea, diarrhea, or vomiting. Indeed, there are reports of it also mimicking appendicitis, and you can see that even in that slide from the cases in New York, there are 2 patients who actually underwent an exploratory laparoscopy. So if you do have facilities available and you want to, for example, just rule out appendicitis, then you may need to do imaging over and above just your clinical examination to help you determine whether there's any surgical intervention needed. I hope I've answered your question. It's still very non-specific. Like I said, the syndrome is still being described. So no specific quadrant or nature of pain. Yeah.
Thank you very much. I think that is now clear. Dr. Maritim?
Good afternoon, everybody. I put up my hand and then my battery drained, so I had to connect the phone on the charger. Thank you so much, Dr. Anne-Marie and team. That was an excellent presentation. And I reflected on something as Dr. Karanja mentioned about the clustering of cases. So about 2 years ago, we had this mysterious outbreak in a school in Muranga, where several girls presented with swollen hand and feet, and we were consulted as a unit of clinical ID, and we even presented a grand round at the School of Medicine. But we didn't have a way, like we looked for everything that we could look for. We looked for those viruses that cause rheumatological conditions. We couldn't find any of them. We looked for parvoviruses. We couldn't find anything. But the girls were otherwise healthy. They didn't have fever. What they presented with were swollen hand and feet, but there were others febrile. And some of them, when they went home, this resolved. And then when they came back to school, they had swollen hands. And it was actually like when the CDC team did the investigation, they did the investigation and then they consulted us to try and find out what is it that was causing. When they did the investigation, they found that most of the girls were within a certain boarding facility, like they were sharing a hostel, they were sharing certain things, and it was even a certain class that was affected. I can't remember whether it was the first formers or the fourth formers. I can't clearly remember. But I'm just wondering, on hindsight, should we have looked for a coronavirus or something like that? Maybe we should revisit this and do additional investigations. I was just thinking, so I needed to hear maybe Dr. Karanja and Marie, what are your thoughts on this? Maybe we'll share with you the case and you can relook at it and see whether it could have been, can you have a milder form that doesn't give you the coronary artery but presents with the swollen hand and feet with minimal symptoms? And they were teenagers and all of them were girls that were affected. I think there was only one boy in that clustering of the disease. Let me hear your thoughts.
Thank you, Mary Beth. Okay. Go ahead, okay. Christine.
Okay. First, the age group is not the age for Kawasaki, but it could be a manifestation of coronavirus, because coronavirus, new symptoms are being described every day. So that it would be interesting to now go back to those girls and just look for the antibodies now. They do a serology, although we don't know how long the antibodies anyway last. It would also be good to know now if we have the SARS-CoV-2 antibodies test available. Those are cases that we could go back to and actually look at. In fact, now as you're talking, Mary Beth, I'm also thinking about those Tarehe girls who, although maybe it was thought to be hysteria, but they presented, I think, late last year with cough, and the symptoms of respiratory disease. Those are people that we could go back to and look for antibodies, so that it would inform us 2 things. One, was it coronavirus? 2, how long do the antibody last, and are they protective antibodies? Thank you. Anne-Marie, go on.
Yeah, I just wanted to agree with you. I was going to say that the age is not typical. And I think the entry point for Kawasaki tends to be that unrelenting fever, yeah, with that respiratory or GE prodrome. And then now the others are sort of varying, but very interesting. I think a lot of people and clinicians do feel that we had coronavirus in the country much earlier than our official cases were reported. I don't know whether 2 years back that would have been the case, but again, coronaviruses are not new, yeah? So the question, like Christine says, maybe would be answered by, if we still have their samples, being able to test them for antibodies at this point. Mary Beth?
There's a comment from Anne Baraza. I'm not sure whether it's the same school, but she says that the Starehe girls was concluded as hepatitis A pneumonia. I don't know whether Dr. Maritim, that was the same institution.
No, the school was called Ihiga Secondary School in Muranga. Ihiga girls. So it's a different school, but I agree, the presentation is different, but at that time we never even thought of coronaviruses, because we know there are so many other human coronaviruses, but they cause a mild respiratory syndrome. But at that time we tried to look for a viral etiology, we looked for so many things, and we couldn't find a cause. So I'm just thinking, like, maybe we just go back and look for one of the coronaviruses and just try to ascertain, because at that time we thought that it could actually be an infectious agent, but up to date we couldn't conclude that case to see what was the cause.
The other thing to think about, very bad, could be a toxin, non-infectious toxin. That could be something also to think about. And then I'm also just weighing in on that hepatitis pneumonia. Well, I don't think I've ever heard of that one. Hepatitis A-related pneumonia causing an outbreak. That one would be new. I don't know. Anne-Marie, have you heard of such a thing?
No, I haven't. No, I haven't. But I do know that early in this outbreak, we did have a private school where we swabbed a number of children. What came up was influenza B. Yeah. So I think in these cases, still we shouldn't also just limit ourselves to corona, other infectious agents. And I completely agree with Christine. In fact, when you mentioned your children, Mary Beth, I thought more of some poisoning, these lead exposures and other environmental toxins.
So we looked for all those, but we couldn't find. So I guess it's one of those like cold cases that we don't have closure, and I guess it will give us a time to reflect and see. But I'll share the slides with both of you, and then maybe if we can follow it up. But I agree, it may not be Kawasaki. At that time, we were thinking of something causing a hand and foot syndrome, but still we couldn't logically conclude. Even the toxin, we looked for it, and then we thought of something they were applying, all of them uniformly, but we couldn't conclude. And they were even reviewed by the rheumatologists. All the tests the rheumatologists requested were inconclusive, including even MRI of the hands did not show like pathology or rheumatological pathology.
Thank you for sharing that experience, Mary Beth. We'll be happy to look at the slide.
Can I please ask a question? This is Dr. Wambani. In relation to the Muranga case, did they ever do any ultrasound of the liver and chest X-ray on those girls?
The chest X-rays were done, they were normal. Ultrasound of the liver, I don't remember that any was done. But you remember the case. Do you remember the case, Dr. Wambani?
I remember it being mentioned, but I had suggested that they do ultrasound of the liver, and then they do chest X-ray, concentration mainly in the right lower lobe because of pleural irritation. That's how you get the chest symptoms in hepatitis.
Oh no, but I think the case for the Muranga girls, they didn't have any chest symptoms. They were actually otherwise well, but only hand and feet that were swollen. The Stare girls that had the chest complaints.
Yeah, I'm thinking about maybe IVC, you know, occlusion, mouth occlusion with the stasis, and getting that swelling of the hands and feet. Because if you have the vena cavas affected, then you tend to swell because you don't have good heart function. You tend to have pooling of fluid in the legs and in the hands. And in the hands, it's so typical how it comes to the swelling of the hands. The description, if you look at them clinically, it's not usual. It swells up to certain level, not the whole forearm or the arm as well, but just the fingers. So, and then of course, looking at the nails, you could probably have elicited some cardiac changes, you know, nail changes due to cardiac failure. So I don't know whether they looked at it clinically that way. I don't know, but it would have been nice if it was done. Over.
Okay, thank you.
We're almost coming to the end of this session. We'll permit Charity Wamboi. You can ask your question. Charity Wamboi, kindly unmute yourself and give your comments. As we wait for Charity, Ahmed Bashir.
Very good. Yeah, we just ask the final questions. Okay.
Ahmed Bashir.
It's mute. You want to listen? You want to hear?
Okay. As I had said, we are almost coming to the end of this session. I will give Dr. Macharia and Dr. Christine a chance to make the final comments on the Kawasaki Syndrome.
Thank you very much. I think my final remarks would be that we should have a high index of suspicion based on the symptoms that we have discussed. And where possible, initiate treatment for these children early, where you make a diagnosis, and preferably within 10 days to prevent the long-term complications. Thank you.
Thank you very much, Dr. Macharia, for your presentation. It's been a good presentation, and the conversations has been engaging. Dr. Christine.
Thank you. By way of just concluding, is just a few remarks. One is that most of the coronavirus disease that we've had in children has been mild. So, you know, when you just hear Kawasaki, hyperinflammatory, there's a tendency to feel that this is what we should really be looking out for, and to be so scared and to start over-diagnosing and over-classifying the fevers as potential Kawasaki. So that is one thing to say. The other thing, I will echo something Anne-Marie said, that sometimes we are condemning our children to coronavirus. You know, we withhold care of a child, maybe with sepsis, because we are waiting for these tests. We feel we cannot handle them. And so they end up dying, even as they wait for the results, whether they turn negative or positive, but it's not coronavirus that is killing them. Then, so we really need to learn, I mean, even with our pediatricians, so that we give good care to our children. The other thing is that with Kawasaki, let us all have a high index of suspicion. Please, because these children, they do very, very well. In fact, when you give them IVIG, they actually, by the time the infusion is over, you can actually see a difference. The first thing to go is the irritability. And then after that, now the fever settles and the other lesions just go down. But some children do not respond to IVIG, and you have to give steroids, especially the very young ones, like the infants. So key thing is that now, because we are here, we are so many of us, we need to make a case for IVIG to be included in the list of essential medicine, so that even out there in the facilities, it can be administered. And because eventually the vasculitis settles, the fever settles, but the heart thing is what even in adults will cause the sudden death and the long-term cardiovascular events. And I'm done.
Okay, thank you so much, Dr. Christine, for that comment. To be included in the essential list, how affordable is it? Okay.
It's an expensive medication. So especially as we continue to see more of these cases, I think there is value in considering.
All right. Thank you for that feedback, Dr. Anne-Marie. There's a very good comment from Christine Gishui. And Christine is saying, as we think of opening schools, maybe there should be education to school healthcare providers so that they facilitate care of most inflammatory. Sorry, let me just mute that. Yeah, so there's a comment from Christine who's suggesting that there should be education to the school healthcare providers. That is the nursing team. Most schools have a nurse who is taking care of the children. Some have a registered doctor, others have a clinician, a clinical officer, but there should be some form of education to the healthcare providers in the schools to facilitate care for multi-inflammatory syndrome quickly. That's a very good comment, Christian, and I agree with you. I couldn't agree with you more. So they should be on the lookout for the symptoms that Dr. Anne-Marie has taken us through, and they should be able to refer this patient to hospital as soon as possible. We'd like to thank all of you for logging into today's session. And we'd like to thank all the people who've made this active, all the panelists, Dr. Anne-Marie Masharia, Dr. Christine Karanja Shege, Dr. Jessica Wambani, Dr. Juliana Muiva, Dr. Mary Beth Maritim, Dr. Rurua Mugo. We thank all of you for making this very active, and all the people who asked their questions. Unfortunately, we are not able to address all the questions, but I hope you're able to follow the discussions, and some of your questions were addressed in the discussion. I'd like to thank my co-host, Dr. Nancy Mkumbao. I think she did a fantastic job. So I'd like to thank her for taking over. And have a nice afternoon. Tomorrow, our session, please note the time for the session tomorrow. Tomorrow, we are having our discussion at night, 7 to 8:30 p.m. And we'll be talking about easing down the COVID-19 disease containment measures. So are we ready for that? We can see Uganda tried opening up, but now they've decided schools will not be opened, the scenario in Rwanda. So that's the discussion we'll be having tomorrow to find out whether we are ready as healthcare workers, whether we are prepared. Thank you for finding time to attend today's session, and have a good afternoon. For those who still have queries on your CPD, please send an email to knhcpd@gmail.com or cpdknhpharmacy@gmail.com for the pharmacist and pharmaceutical technologists. Have a good afternoon, and bye.